Thank you, Ray. Hello, everyone. I'm really excited to share my findings and what we've been doing in Pakistan. So I'll start with my journey. If you can see in the background, this is the map of my country, Pakistan. And the red maps, the red icons show in this hospital, network hospitals throughout Pakistan. So our organization is basically a private hospital, but it's a free hospital. We don't have a cash counter in a hospital at all, and we serve the poor, the rich equally, and we do not charge them. So I belong to Karachi here, this one, the Sindh province, and above you can see the hospital where I actually belong to. So actually, my journey starts with while I was attending one of the conferences, and I heard Marie talk, and she was talking about infants under 6 months and how they were working on MAMI, and it really excited me. And then I corresponded with her, and this is how she shared her version 3 of MAMI package. And with her help and all the people in ENL, they helped me a lot, especially Marco, Nikki, Hedwig. And with their help, I was able to establish MAMI Care Pathway in my hospital. The package here in my hospital is different because many of us operate in the communities, but we've been doing it as a facility-based MAMI care package. And so the facility-based MAMI care started in October 2021. The clinics are thrice, they're run thrice in pediatric OPD, and they're manned by the consultants and also by the pediatric fellows because we have a pediatric residency program. And we have adopted this clinic, MAMI clinic, all the workings and all the procedures from MAMI Care Pathway Package version 3. Can I have the next slide, please? Okay, so got it published too. We did a learning by doing case study series from Pakistan, and that talked about it, but that was almost 2 years ago now. But let me walk you through all the process we do. So the scope of our integrated care for mother and infant is that we screen them, monitor them, both the mother and the infants, for the growth issues, for nutritional status, for medical problems, and mental health. Medical health problems is it's really working well for us because we are sitting in a tertiary care hospital. So if we identify any medical problems that need to be seen by a specialist, like cardiac illnesses or hypothyroidism, we refer them from our clinic to the respective consultants and then back to us. We also offer counseling for feeding practices, for hygiene, especially wash strategies, for family planning and vaccination. Then a follow-up is planned. Usually, as MAMI Care Pathway recommends, we follow these infants till 6 months. And in between, if we need the field for referral, we refer them to specialized medical services and the mothers for mental health assessment and for management. We just started a small project with 1 or 2 psychologists who are addressing maternal mental health issues. So this is the way it is. Please, next slide. There is one more. Okay. So then these are the components which I was talking about. So when first the child comes to our clinic, the child undergoes a triage. And the triage is basically watching for danger signs and for the vitals. And if we identify any child who has problem and he needs acute medical care, then either the infant is referred to emergency department or referred for inpatient admission. This is followed by their growth monitoring. We take their weight, height, and plot them on the growth charts. And we also take the MUAC of the mother and the baby and place them actually in which group are they. Because we are offering counseling and we're also mixing these children with the mainstream pediatric clinics. So important for us to know how we monitor their growth. And Indus Hospital is actually, I'm lucky to be working in this hospital. Our hospital is a paperless hospital. So we have everything on computers. So we have growth charts. With the help of our IT team, we have put all the growth charts in the follow-up. And when a child comes in, we just click the trajectory, the graph, and it shows what standard deviation score the child lies on and what is the classification of the child. So this is how we are triaging them on the basis of nutrition. Then this is followed by counseling. The mothers are counseled for those, for the breastfeeding. If any mom has any breastfeeding problem, then we observe the breastfeeding and we counsel them. Then we talk about complementary feeding because this is the time when mothers are really receptive, and it's good to make them accustomed to the good complementary feeding practices. So we talk about IYCF. Then we screen them for medical problems, especially for congenital heart disease and congenital hypothyroidism. Then they're followed. Usually, if there's no problem, then we follow them at 3 months and the second follow-up at 6 months. But if we identify any red flags, then as per need, we call them in more frequent follow-ups. Then the maternal condition. So there are basically three things we are following the mothers for. Number one, maternal undernutrition. And as I mentioned, that we're using mother's MUAC and we're using the cutoff of 23 centimeters for mom's nutritional status. Then we are looking for anemia because in Pakistan, maternal anemia is a huge problem. So we are giving them medicines also, and we're looking for anemia, but we usually just do it clinically. And if need be, then we refer them to the adult doctors for, if we think that they need iron supplements or they need a transfusion. And recently we've started mental health screening and addressing them, sending them to psychologists. So I think many of you are aware that in MAMI Care Pathway, we are using Patient Health Questionnaire 9, which is called PHQ-9. And it's a very useful but very brief screening tool to screen mothers for mental illnesses. So what we're doing is for the past 1 year, and the next presentation is going to be on it too, since last year, we started formal screening. So any mother who was a red flag on PHQ-9, we referred them to assessment through Edinburgh postnatal depression screening tool. And if we identified depression through this screening tool as well, we would send them for formal counseling to the psychologist. This has been going on for a year now, and I will share the data about this too. Can I have the next slide, please? So this is what another thing, so mental health is one thing we've added. Another thing which we've recently added, it's been 2 months now, that we are looking for developmental screening. You see, Pakistan, like many other lower middle countries, we do not have a very robust infant delivery system. Many of the mothers, they have home deliveries. Many of the mothers don't come for regular antenatal checkups. So we have a guy, OBGYN in our hospital, and we've been noticing that, children, they have problems. So we are usually picking up only those infants who are born in our hospital. Since we know their medical history, we know that we flag those infants. For example, infants who have had neonatal admissions, who have had extreme degree of jaundice resulting in mental problems, or who have asphyxia and stuff like that. So the problematic infants are flagged, and we follow them for the developmental screening. We try to screen them at 3 months, but I think at 3 months was very difficult because their tone doesn't change much, and they're not much milestones to pick up from. And maybe a neurologist may be a good person to pick up early signs, but for us, it was difficult and we were missing cases. So we finally started screening them at 6 months of age. And we're using a Heinz screening score, which assesses them for their tone, for their motor milestones and stuff like that. And if we find any problem, if we find that they're lagging behind their developmental milestones, we refer them for rehabilitation. So this is one thing we've recently started. Can I have the next slide? So this is the patient journey. You can see on the left, this is the triage room I was talking about. In this room, we take their height, weight, length, weight, and MUAC. Also, we screen them for danger signs. In the picture below, you can see our nutrition nurse. She's taking mother's MUAC while the mother holds her baby in her lap. So a typical journey for a child and a mother dyad who comes to our hospital is that the dyad, they first get enrolled. We get feeding of our clinic from NICU, from our family medicine clinics, and from the pediatric clinics. The first assessment is with triage with vital signs, and if the danger signs are present, they are referred to emergency or inpatient department. Then a detailed assessment is done and management of infant mother dyad problems is done. The components I've already discussed, all those are taken up one by one. And the data is, since I told you that we are a computer-based hospital, so we're putting in the data on a template which is in the computer. Then follow-up is done. First follow-up is done at 3 months. Next slide, please, Ray. And then the final follow-up is done at 6 months. At this 6-month end follow-up, we do a comprehensive review of the infant's development, mother's mental health, and child's growth and feeding assessment. And that is the time when we ask mothers to introduce complementary feeding. So the OPD, the MAMI clinic, is done on the 1st floor, and the pediatric ward is on the 10th floor. So we have a kitchen in our hospital, in our ward, where the mothers and the nurses, they make food, the complementary food, culturally commonly available in Pakistan. We train mothers for their how to make them. So, the nurse brings the food from the ward in the OPD, and we try teaching mothers how to start with complementary feeding, because usually this is the last visit they are going to have with us in MAMI. And if we feel there's a problem, for example, there's issues with growth, there's problem with feeding practices, if a mom is struggling with her breastfeeding and so on, then we integrate them in the mainstream pediatric clinics. But when we integrate them, we can still see in our computers that these are the infants who are coming from MAMI. So by that time, we have a really pretty good rapport with the mother as well. So it goes quite smoothly for us. And then we also document the outcomes. We document every 2 months, we sit together, me and there's a research associate who's involved, and we look at the data. And we try to make tweaks if we see problems. If, for instance, if there's too much feeding in the clinic, then we try to decrease it, and the mothers are not showing up, then we increase the follow-up and stuff like that. And all the data is recorded in the RedCap software. So now I'm going to share what up till now, a little bit data of what we've been doing since 2021. Can I have the next slide, please? So this data was capped till September 2025 for the meeting. So till now, we have screened 3,442 infant mother dyads. The males are 54% and the females are 46%. We separate term infants from preterm infants. So majority as expected were the term infants, 82, but remaining were preterm infants. The median maternal age in our cohort is 27 years. And maternal MUAC in centimeters was 25. So most of them, yes, the minimum and max are there, but they were not that malnourished, but the anemia was there, as we suspected. Now the next slide is very interesting for me. So if you look at this table, what we did was we separated the preterm from the term infants. And we know the WHO guidelines 2023. It has recommended a cutoff of 110 millimeter or 11 centimeter MUAC for an infant aged 6 weeks to 6 months. So an infant whose age is between 6 weeks to 6 months and who has a MUAC of 11 centimeter is at risk of mortality and is considered a red flag. And the recommendations are either to admit them or follow them quickly, more robustly and with short intervals. So, but and there is no actually data, I didn't come across any data on age-specific MUAC. And it's difficult. I understand that MUAC values change rapidly in growing infants, and it's a cumbersome procedure. But what we attempted to do, since we had everything with us, we tried to calculate age-specific MUAC in 3 age groups. For infants from 0 to less than 2 months, then between 2 to 4 months of age, and then more than 4 months, essentially it's 4 to 7 months of age. And we tried to correlate the MUAC and age-specific MUAC with the 3 nutritional status on the basis of weight for age Z-score. So on the left, you can see preterm. Then the preterm, there are 3 categories of weight for age Z-score. It's less than 3 SD, which is severe malnutrition, less than 2 SD, which is moderate malnutrition, and 1 SD, which is a normal infant. And the same is for term. So if you can just quickly look at it, then you see that for preterm infants and for the term, there is a variation of almost 1 centimeter, which is quite a lot. So, this has been reported as well. in many nutrition programs, they've noted that infants less than 6 months, they had MUAC as low as 9 centimeter. And this is what we came across. But one interesting thing to note here is that if you look at the ranges, then in preterm, in less than 2 months, the severe malnutrition corresponding MUAC was 8, while when they reached the age of 4 months, it was 12.5. So actually, these preterms were catching up. And for terms, there was the range was from 13 centimeter to 9 centimeter. Now, if you see this, another interesting thing which needs to be noted here is that if you look at pretermers, the pretermers in 2 to 4 month age group, 1 SD score of weight for age corresponds with a MUAC of 11 centimeter. And if you look at the terms, then in less than 2 months, 1 SD score corresponds with 11 centimeter. So this is actually a problem now, because you see, I understand that we try to capture the infants who are at risk of mortality. So if we use a cutoff of 11 centimeter for all age groups from 6 weeks to 6 months, then 11 centimeter or 110 millimeter works well. It actually picks up all the MUAC values less than 11. But it's actually overdiagnosing. And this was something which has been cited by many authors and by many doctors who are working in malnutrition field, that we tend to overdiagnose. So essentially, if I look at this data, a term infant having age less than 2 months with a MUAC of 11 would be normal. But since this is the guideline I'm using through WHO, I will still consider admitting him, and I will still call him for frequent follow-ups. So I think 6 months ago, we started this exercise that we're looking at the pretermers and we were looking at the term infants who had a MUAC cutoff of 11. And when we visually saw them, they were not malnourished. They were just small, but they were not malnourished. So I think this is a food for thought. I think we need researchers to confirm age-specific MUAC and to have some understanding of the connection of two anthropometric indicators, which is MUAC and weight for age. Because we know that MUAC is a very good tool. It's very convenient and feasible and can be widely used in the community setup. So if we have some degree of understanding that which MUAC corresponds with which weight for age Z-score, in which age groups, then I think it will be safe in screening infants with mid-upper arm circumference. Now, that's just a thought, and I think much research needs to be done in this regard. So this ends my first presentation. I think we can continue with the question and answers after I'm done with the second presentation too. So as I told you that since last year, we actually started screening moms, those who were red flagged on PHQ-9. We screened them with a formal postnatal depression score, and we collected the data for 1 year. So this got published. This is a local Pakistani journal, and the first author is my resident, and I'm the second one. Can I have the next slide? So this is a cross-sectional study, started from July 2023 till July 2024. The objectives of our study was to screen postpartum depression in mothers having infants under 6 months and determine the risk factor of postpartum depression. We also looked at the association of postpartum depression with nutritional status of the babies, the feeding practices of the babies, and vaccination status of infants. Next slide, please. So this is the overview. What we did was that if mothers scored more than 10 on PHQ-9, which suggests depression, we proceeded with the EPDS score, which is Edinburgh Postnatal Depression Scale, for further evaluation of depression. The Edinburgh Postnatal Depression Scale, I think Ray will share the questionnaire with you all later. It's essentially a set of questions which assess mothers for their happiness, for their suicidal tendencies, for their depression, for the interest in environment and in the baby. So the scoring is that if you have a score of 0 to 8, it means no depression. A score of 9 to 11 means probable depression, and more than 12 means depression. We assess the infants at the same time for the nutritional status through weight for age Z-score and length for age Z-score. And the data was collected again through REDCap and SPSS software. You can have the next slide, please. So these are the key findings. A total of 530 mothers were screened using PHQ-9. And 123 out of those 30 moms qualified to be screened by EPDS2. When we screened them, what we found was that for 52% mothers had no depression. 27% had probable depression and 21% had depression. The risk factors for maternal depression, which was statistically significant, came out to be low family income, nuclear family structures, and preterm births. Nuclear family structure was actually a really surprising thing for us because, you know, in Pakistan, we promote, Pakistan, usually we have large, big family sizes. So 2 or 3 rooms with 20 people living in it. Though it has its, you know, it has its pros and cons too. There are too many mouths to feed. There are too many communicable diseases running in the same household. But the moms, they said when those moms who were living alone with their family only, they were more depressed. And when we asked them why, they said that they had no help to help them in chores, household chores. Some of them were working and they were struggling to take care of the baby and stuff like that. In the vaccination status, the infants of the depressed mothers, only few of them were completely vaccinated. Most of them had partial vaccination. There was increased bottle feeding trend among depressed mothers, and all infants of depressed mothers were malnourished based on weight for age and length for age Z-score. Can I have the next slide? The graph I'm going to show you is an eye-opener. This graph talks about maternal depression and infant growth status. If you look here on the left, there is no depression. And if the mom has no depression, then both on basis of weight and length, there's 100% nutritional status of the infants. We did not find any malnourished child in this group. Then those mothers who had possible depression, you can see the nutritional status going down. It came down from 100% to 61%, both on the basis of weight for age and length for age. And if you look at the high depression group, it's so sad to see that almost all of the children were malnourished. There was a mix of moderate and severe malnutrition, but they had some kind of malnutrition, and not a single child was well nourished in this group. Can I have the next slide, please? So take-home messages from my presentation is that mothers' physical and mental health contribute significantly to infants' growth and nutritional status. A mother's well-being is the foundation of an infant's future. If you want thriving infants, it starts with the mom. Thank you.